Hello, my name is Dr. Marla Dubinsky. I am Chief of Gastroenterology and Hepatology at the Icahn School of Medicine, Mount Sinai Hospital in New York, and the co-director of the Susan and Leonard Feinstein IBD Clinical Center. And I'm joined today by Dr. Joel Rosh, who's Professor of Pediatrics at the Icahn School of Medicine, Mount Sinai Hospital, and Chief of Pediatric Gastroenterology and Hepatology at the Goriad Children's Hospital in Morristown, New Jersey. We're here today to share with you an expert perspective from the Great Debates and Updates in Inflammatory Bowel Disease meeting taking place in San Francisco. Welcome, Joel.
Thank you, Marla.
First, we're going to start with focusing really on the pediatric expert perspective. So what I was really most intrigued about with your agenda that you shared with the group and the attendees was this focus on translational medicine and how some of the findings we see from some of these big, large pediatric cohorts, how we're learning to translate that to what it means in treatment choices, prognosis, early intervention. So can we start by talking a little bit about what we've learned from some of these cohorts, specifically maybe genetics? Let's start with that.
Sure, absolutely. Yes, you're right. I mean, anytime we get together and talk about IBD, we always show this three-ring circus of genetics, environment, and the gut microbiome and how they interact to cause IBD. And we tried to drill down on that at our meeting today. So first we kicked off with Dr. Judith Kelson from Children's Hospital of Philadelphia. And Judith used the very early onset IBD as a model. We recognize that IBD, when it presents, at what age it presents, can help inform us on what type of disease we're going to see. So when we define very early IBD, let's say in children less than 5 or less than 6, we see a colonic predominant disease that presents with bloody diarrhea. Much more of a genetic signal there than environment because they haven't been around long enough to be influenced by the environment. So genetics more than epigenetics are going to inform us. And Judith looked at studies from large consortiums of children who present at those ages to help us understand the genetics of IBD.
But does that change treatment, I guess? So some may say, okay, it's interesting, you've got genetics that define presentation maybe, so you're saying a more colonic-based approach in terms of treatment, but they may respond differently to treatment. So is there anything we should take home from that expert perspective on what we can learn from that cohort and how we can take that home tomorrow to practice in our clinic?
That's an excellent question. So probably the biggest piece of information we get from the very early onset IBD is to remind us the fact that we're not really talking about two diseases. It's not just Crohn's disease. It's not just ulcerative colitis. There are different diseases under both of those umbrellas. And looking at the fact that the disease can be so different in the very early onset helps remind us to individualize our therapy, think about our patients not as just one big group. Oh, how do you treat Crohn's disease? Well, which Crohn's disease are we talking about? What patient are we talking about? So it serves as a model, as a rubric for us to approach any individual patient and try to personalize the therapy.
So I know that some of the work from Boston in particular as well has shown that even the children that are less than 2 or within 1 year of birth who have a particular gene defect thought to be identified as Crohn's-like, but maybe it's just a clear immunodeficiency, that only bone marrow transplant is really the sole treatment. So maybe speak to that difference between the IBD patient who presents at the age of 5 with pancolitis, IBD unspecified, not sure what they are, and versus that new kind of IL-10 receptor defect type patient in the CGD pathway of genetics. I don't know what you think about how that may apply to our viewers as well.
Right, so absolutely. So in those particular children that you're referring to, this is a presentation of colonic disease with highly destructive perianal disease. And don't make the mistake of giving them an anti-TNF. You're going to need your bone marrow transplant team to mobilize. So there's the ultimate where we actually are smart enough now to recognize this is a specific phenotype. Let's isolate the genotype, and based upon that, we know what treatment to give, and that's bone marrow transplant. And we all hope for that day where I'll have a gene chip in clinic. I can drop a drop of your blood on it, put it in, know your genes, and I know exactly the therapy for it. We have one type now where we do, and that's the IL-10.
So you mentioned this kind of Venn diagram. You actually called it a 3-ring circus, but I'm going to imagine as being the Venn diagram, and you noted genetics, And now let's talk about microbiome, because you did mention the concept that we are gaining a better understanding of the role of microbiome, and the cohort that we're both working with on the risk cohort, Dr. Markowitz presented some preliminary data on how we may use microbial research into practice. So
That's
maybe
right.
share.
Yeah, so Jim Markowitz from Hofstra Medical School in Long Island brought us up to date on what we're learning from risk. So the risk cohort that your center, our center, and 20-something centers in North America, led by Super Kugathason, the primary investigator, and funded through CCFA, are taking a well-characterized cohort of children at the time of diagnosis, and we're collecting translational data, stool for the microbiome, serology, which I know is of interest to you, and the genetics of these children to help better understand when we diagnose a patient, rather than saying you have Crohn's disease and just give you the umbrella, let's see if we can better understand exactly which phenotype and genotype of disease you have and how likely are you to progress. With that, let's understand the microbiome that's present in that child when we diagnose them. And from the risk cohort, we've already had several publications on gut microbiome, which is very informative. We've learned that the microbiome that's present in a child at the time of Crohn's disease diagnosis is less diverse and shunted towards an inflammatory signature. We've also learned, for a long time, we thought, oh, maybe if we could just scoop the poop and look at what bugs are in their stool, we'll understand better. It's not that simple. It's actually the gut adherent, the mucosal adherent bacteria that are most important, and that's not well reflected in what's in the stool. So if we're going to move microbiome research forward, which is happening today, we're going to need to look at the mucosa and the bacteria that are adherent to the mucosa. Another question that always comes up, a very practical question, is what is the role of antibiotics? And I certainly grew up in an era where we used a lot of antibiotics to treat Crohn's disease. And it's becoming a real question whether antibiotics are doing the work of the devil or helping us in inflammatory bowel disease.
So I think it leads to two really important topics that a lot of people are interested in, is the role of diet on the microbiome. And it's easy, I feel, in animal models. You can isolate, you can manipulate what foods they get. But in a human, the microbiome is a lot more complex because there's so many things that can impact the microbial composition. So I'm not sure what your thoughts are, what the audience would think about the idea of fecal microbial transplant, altering the microbiota, maybe even in a preclinical state, taking the lessons from risk and saying, okay, we got them at the time of diagnosis. Maybe we could have looked a little bit earlier and seen that that patient was heading towards that microbiome pattern that is inflammatory. Could we have stopped it? Could we have changed it? Role of diet, maybe that's where antibiotics are either positive or negative impact. Role of fecal microbial transplant. So maybe highlight a little bit in the context of the microbiome.
Yes, I think you just brought up 3 potential Nobel Prize winning projects.
That's my goal.
There you are. Yeah, it's both exciting and daunting. If let's take the question of a sibling. So child 1 is just diagnosed with Crohn's disease. What about the siblings? I'm recognizing there probably is a genetic hit there. There's innate immunity wiring that's predisposing them to inflammatory bowel disease. Can I manipulate their microbiome so they don't get inflammatory bowel disease? I'm sure you get asked that question. I know I get asked that question by every parent when we diagnose a child with an IBD. What about my other children? What can I do to prevent it? So the questions are being asked. We don't have the answers yet. We do worry about the indiscriminate use of antibiotics, and is that going to push the microbiome in a wrong direction? So I think we should at least be cautious in that family.
I think the way I think about it is that patients, they think automatically we're going to have kind of an adverse reaction to the idea of diet and wanting to use diet to help cure the disease, which we know we need to rephrase our language in our discussion with our patients. But I'm actually becoming more and more interested in kind of teaching the patients that I believe strongly in the impact of diet or whatever we're doing to manipulate the luminal environment that the mucosa sits in. Trying to separate the impact of the luminal environment with therapies or diet compared to the systemic exposure. And probably you need both. I mean, it's a genetic disease. You talked about that originally. I kind of view it like once the inflammatory ulcers are there, the horse is out of the barn, and I try and explain that just manipulating the bacteria for which that tap is just pouring out inflammatory cytokines itself isn't going to be, especially in Crohn's with a transmural disease process, we really need to talk about synergy. So I'm starting to engage my patients in saying, I totally believe in the concept of manipulating the microbiome. I think we'd be hiding our heads in the sands as clinicians to say it's all about drug. It's all about drug. I think it's really about a combination of the kind of Eastern and Western approach to lumen as well as systemic. So I'm glad that you brought up and introduced the concept that from a pediatric perspective, we're really thinking about the microbiome, and we're thinking about diet, and we're thinking about ways to see how the body's genetic susceptibility is reacting to the gut flora.
Absolutely.
It's very exciting. So now to switch gears and kind of bring it home to the clinic, of those pitfalls you discussed about pitfalls in the management of the pediatric patient, what are kind of 5 lessons we learned on what not to do, and then what are corrective actions we can educate pediatric gastroenterologists or caregivers or even patients who may be watching this interaction? What's the take-home messages about what we can do better and what we are doing well already and how to fix it?
Yeah, so I'm glad you brought that up. We had wonderful panel discussions of common scenarios that a lot of people, you'll probably see it on Monday when you do a second opinion. And you sort of look at the case, and now it's Monday morning, you feel like that Monday morning quarterback, and you say, oh, I only wish I had done this, or I only wish the physician had done this, and we've all done it ourselves. And so we had a very honest, open discussion of pretty much the common mistakes that we've made too many times and we've learned not to make. Some of them centered around focusing on symptoms as defining inflammatory activity. So we recognize that gastrointestinal symptoms are very nonspecific. We talk about applying the Crohn's disease activity index to our irritable bowel patients and how high they would score. And so am I going to change potent immunosuppression just based upon symptoms alone? And the answer certainly is, let's not do that anymore. By the same token, we're not also going to assume that a patient is doing well because I walk into the office Monday morning and say, how are you feeling today, Johnny? And he says, fine. I say, okay, we're done. We're going to look much more carefully at our patients. And so concepts of mucosal healing started to emerge, concepts of therapeutic drug monitoring started to emerge, and we can talk more about those in a minute. But the overriding concept was that a good history, physical and objective criteria need to be present to really know what's going on with our patients. We talked a lot about growth as a very important outcome in pediatric IBD, especially in recognizing that the average age of diagnosis is 11, 12. So it's just when children are starting to enter into that pubertal growth spurt, we need to be very mindful of that long-term outcome. To the point, we brought up a case of a typical ulcerative colitis patient who comes into the office and says they're not doing well. And the impulse right away would be, okay, let me write you a prescription for prednisone. When we really drilled down on what I'm not doing well, it was, I sometimes see a little blood in my stool. And maybe that's a patient who would do great on some rectal therapy in addition to their oral 5-ASA that they've been doing beautifully on for a very long time. And so one of the common pitfalls in pediatric ulcerative colitis, I think, that we see is forgetting rectal therapy as an adjunct therapy in controlling that disease.
So you brought up 2 really interesting points. One is this concept of disease monitoring and objective measures, which hopefully we'll get into a little bit also when we talk about the adult perspective. So how I took away some interesting points from our other day at the meeting. And the concept that maybe with children, growth failure in particular is something we underestimate the degree of the inflammatory burden. And trying to relate to families is what I struggle with. I feel like my whole Monday is filled with this conversation. It's my child feels well, in quotation marks. One, they've had it for so long, they probably don't know what it's like to actually feel really well. They've compensated. I feel fine. And the idea of translating that when you look at the growth chart and you see that they're below the 5th percentile and you track it back to what age their bones would be and get a bone age, and you justify the idea that when you track it back, well, the median for that weight was a 7-year-old and the patient's 9.5 sitting in front of you. How to explain to families the difference between growth hormone deficiency and growth resistance that we see in the face of chronic inflammation, and maybe separating that the growth failure is indeed an objective measure, not just a calprotectin, which we talk about, or not just a colonoscopy, but maybe growth failure is actually a very important window for us to look into, and maybe we should be a little bit more assertive and effective with these families in terms of saying 5 ASAs is not going to cut it for your child who's having this significant growth failure. Do you find that a difficult conversation sometimes?
Very difficult, and we actually talked a lot about that. And one example that came up, and that I personally find very helpful, I explained to families, I have a big challenge. If I was a dermatologist, it would be so much easier. Your child has a rash. I give them a therapy. I say, how's your child doing? You don't tell me about how he feels and whether he's going to school or not. You pick up a shirt and you show me his rash and we know how he's doing. Whereas in gastroenterology, because everything's happening on the inside, we're more challenged. So when I want to know how your child is doing, yes, I want to hear about all those quality of life measures and I want to hear about those subjective measures. But at the end of the day, I want to control the inflammation too. But for me to see their rash, it might be a little more challenging than it is for the dermatologist. And sometimes I find that conversation a little bit helpful, and then now they're engaged. They want to know, okay, so how do you check my child's rash? And that's where we start talking about C-reactive proteins and calprotectin in the stool, and perhaps even a repeat endoscopy and looking at the mucosa. So helping people to understand that there's a Mack truck around the corner that's about to hit your child. You don't see it yet, but I do. And we need to think about what's happening 3 steps down the line. And a great marker for that is the growth velocity, because that at the end of the day is our hemoglobin A1C. That's our long-term marker of how well controlled your disease is.
So I think you've brought up some really great points about what highlighted the importance of this focused pediatric perspective. I think there are definitely unique features that, especially as it relates to the growth plate and what we're learning from these cohort studies in pediatrics, where our adult perspectives could change based on the pediatric perspective. So I want to thank you for sharing the important perspectives from a pediatric side. And I think when we look to speaking about the adult perspective, that you're going to see there's some similarities as it relates to what's our target. So I hope that we'll talk further about that. So I want to thank you very much for joining me today, and I want to thank all of the viewers for joining Dr. Rosh and I as we explore the pediatric perspectives. And I think that you'll also enjoy when we discuss the adult perspectives from the great debates and updates in inflammatory bowel disease. Thank you.